enterocutaneous fistula? Can you define an enterocutaneous fistula? Go ahead, Shu. Enterocutaneous fistula.
This is an abnormal communication between the epithelial surface of the skin and bowel.
Very good. So, very good. Now, along with this, like the definition of hernia, we have one more thing, that is the spontaneous drainage of contents, right? So it is basically an abnormal communication between the skin and the bowel with a spontaneous drainage of the contents, right? So that is the definition of a EC fistula, right? So that is the definition of an EC fistula. So now coming to something more tricky. Now examiner knows you've passed. Question comes, what in an enteroatmospheric fistula? This is difficult. If you can give me an answer. So, see, suppose this was the abdomen. You've had a burst abdomen, you've repaired it, but somehow it is not working. You've left it open and it is healed by granulation tissue. It was an open abdomen and there was a lot of pus coming out from here. Some part also enteric content. So what you've done, you've put something on top of this, a bag like this. Can you name this bag? What is this bag called?
Bagota bag.
Wound manager.
Wound manager.
It is called a wound manager. So this is technically an open abdomen. Now there is a classification of one open abdomen called the York classification. It is called the York classification. Okay. And from there, what happens is that if you have a type 3 open abdomen, that is generally complicated by a fistula, that is called an enteroatmospheric fistula, right? So the York classification, just to tell you that, of course, this is the type 3 York, okay, wound dehiscence with some sort of a fistula, right? So there was a description given in 2009, and of course now what we follow is the York 2016. So this is technically the open abdomen, right? So this is the open abdomen. So from the basically the 3A, it has now come down to 3-4. Okay. Sorry, to 4. So this is basically the York classification. You need not remember it. Again, it's a little bit on the trickier side, but I doubt unless and until you're answering very well, you will not be poked into this domain. Right. So I'm sorry I couldn't share the images of this. I have an archive of images, but again, this came as a very short notice to me, and I'm generally out of general surgery for a very long time. But still, nevertheless, the image will look like something of this sort. Okay. So now, can we classify enterocutaneous fistulas? Go ahead. How can you classify enterocutaneous fistulas?
Yes.
According to the output, high output fistula and low output fistula.
Very good. Then
Based on the communications, like on the site of origin also.
okay. Anything else?
Based on location.
Very good. So I will just give you something. You can take screenshots if you want, and if you want, I'll send this PPT over to Shilajit and you can have it. You can just text me on WhatsApp, I'll share it with you. So now, if you say something which is physiological, right, that is the output, right, you said. So low output is less than 200, moderate is 200 to 500, and high output is more than 500, right? Now, from the etiology, you can have something which is a primary ECF and you have something which is a secondary ECF. Primary ECF is generally a spontaneous, like you can see in Crohn's. IBD, Crohn's. Crohn's UC will come in the exam. Okay. Tuberculosis, some other uncommon things like actinomycosis, okay, malignancy, diverticulosis, all of these things. Secondary, if you have, say, anastomotic dehiscence. So this is like one of the most common reasons why we have EC fistulas are because of our surgical technique. And of course, we have radiation enteritis also. And certain cases, if you see, there are congenital things like the patent urachus from where you can have the vitalointestinal duct. From there, you can have these patients ooze out some sort of a liquidy content. That is the congenital VID. You can have malignancy, you can have iatrogenic also, and all of these things are the causes of enterocutaneous fistula, right? So I have you in the loop here, right? You can understand, or do I need to repeat this? Hello? Are you fine with me so far?
Yes, sir.
Okay. Right. So can you tell me the risk factors of VC fistula? Go ahead.
According to patient's factor, age, then nutritional factor,
Very good.
then according
Disease.
to the procedure, emergency and elective procedure.
Very good. Very good. Then
Malnutrition,
very
presence
good.
of foreign body, presence of any distal obstruction.
Very good.
Uh,
Something very common, like your boss asked you to open the abdomen and you can't do it. There is something inside. What is inside?
Hydrogenic thing.
Yeah. What will be there? Nitrogenic because of what? Additions, no?
Yes.
Yeah. So that is the thing. So very rightly said. So pre-operative, like you said, it's a redo surgery. Whether there is malnutrition, where the albumin is less, you have IBD, you have active sepsis, you have steroid use, you have some sort of an intra-abdominal sepsis. Of course, you can include the radiation enteritis and all of these things. So the thing is, these are the main risk factors. So pre-operative optimization, or what is called a prehabilitation, is something of paramount importance when it comes to major surgery, right? Now, coming to the perioperative ones, like you said, emergency surgery, extensive adhesiolysis, which will cause inadvertently cause enterotomies, and of course, if you are asking your first year resident to do an anastomosis, or you're teaching, I'm not demeaning any first year resident, but of course, the thing is unsupervised, unmentored anastomosis, you can have some sort of leaks, right? So you need to address these things, and of course, a post-operative factor includes your re-laparotomy. Now, there is something called a hostile abdomen. Now, hostile abdomen is basically a period between this 10 days, or rather 7 days to 6 weeks. So if you have to re-explore from the index surgery, you explore by 7 days, or you explore after 6 weeks. So this is a good phase, this is a good phase, this is not a good phase. So this time is called the hostile abdomen. You're going to have so much of additions that you will end up doing some sort of problem there. Okay. So I remember very recently, the thing is, like, what happens is that you might end up having cases at times that people are asking you that kindly do this case. So one case has come to me from ESI Medical College, and that gentleman underwent a Hartmann's in a rectal cancer. Of course, you don't do Hartmann's in primary rectal cancer nowadays unless there is an obstruction, but still you don't do it. So you generally go for radiation with a iostomy. Now, some of this person had a Hartmann's, and trust me, when I went in for a takedown of the Hartmann's, it was so horrible that the ureter was stuck to the colons, very badly adhered, no planes. Okay, very difficult surgery. So that is something which is called a hostile abdomen. So that is when, like, you are asking for some sort of trouble, right? So very carefully and meticulously you have to manage these patients, right? Now, basically, from one stoma, you go back to another stoma. So you did a Hartmann's takedown. Now you have to divert proximally to an ileostomy. So what is the point? So that is basically hostile abdomen. So don't intervene in that period. So next, come to the outline the principles of enterocutaneous fistula. Okay, so this I think you will be able to answer. Can you tell me